Welcome everybody to today's webinar on Revenue Cycle Management, or RCM. My name is Mark Clark. I'm the Vice President of Marketing for Advanced Data Systems, and actually the webinar today is not about RCM, it's about RCM with the emphasis on the M. You'll hear more about that as the webinar starts in about 2 minutes. First though, just a couple of words on ADS so that everyone knows who we are and what we do. We produce the Medic suite of software solutions for medical practices, enterprise groups, really of any size or specialty. Our software brings new levels of automation to our clients who use our systems in order to see more patients, to operate more efficiently, and to generate more revenue. We are entering, as you can see, our 40th year in the industry, which we think speaks volumes about our stability and reliability. The company's more than 200 team members are dedicated to creating great software, to providing clients with comprehensive system training, to providing excellent customer support, and to offering IT services to clients as needed. Now, while you can obtain your own Medic system, what is no doubt of interest to everyone on the call today is something else, outsourced RCM. And that brings us to today's webinar. The presenters that you're about to hear from are absolute powerhouses of knowledge when it comes to coding, billing, and the overall management and operational aspects of medical practices and groups. Ira Spector is not only a certified coder who knows virtually every nuance there is to know about coding, how to maximize coding, and what to look for in an RCM company. He's also an MD, an OBGYN to be exact. So he can speak with some extra special authority on the subjects. Terry Spector is a complete expert on the financial and operational sides of medical practice management, and together they are a formidable team on billing, coding, practice management procedures, and on RCM. So on to the webinar, which I believe will be started by Dr. Spector.
Thank you, Mark, for that lovely introduction. What we're going to be talking about today is revenue cycle management. And what is revenue cycle management? Most practices just believe that it has to do with billing and collection. But it's more than that. It has to do with the whole process of getting the money in, not only the billing and collection part. The definition of revenue cycle management is the financial process that healthcare facilities use to track patient care episodes from registration and the appointment scheduling to the final payment of a balance. So it encompasses way more than just the act of pressing the button to bill claims and pressing a button to collect money. Physicians typically don't spend enough time taking care of the practice's business. Physicians nowadays are so stressed by having to see patients at an increased rate in order to make their practices profitable that they don't spend the time taking care of the business. And that's a mistake, because if you take care of the business, you'll have more revenue and you'll have more time to take better care of your patients. Okay, now what do physicians know? They know what they take in each month. Okay, they don't know what they could take in or what they should have taken in with the proper management. And this is pervasive throughout practices, even practices that belong to hospitals. These physicians really don't know what they could be taking in from the work they're doing. There's so many different rules out there, so many different payers. It's almost impossible for an individual practice or even a group practice to know what they need to know to bill and collect effectively. And they need help doing this. There's no question. This slide that we're looking at now is really, really important. These are all the points that are involved in revenue cycle management. It's from making the appointment all the way to the reports and analyses at the end. What you see in red here and pink is what billing companies normally do. This is what billing companies call RCM. Sending out the bill, confirming that the bill went out, doing some collections. The amount of denial management is questionable, appeals are questionable, and often there's problem in posting the payments with write-offs that shouldn't be done. Reports and analyses, all these companies give reports, but analyzing the practices business in order to give the owners of the practice, the physicians, information to run their practices effectively is not there. Now let's look at some of these things. Now a lot of these bullet points can be an hour discussion on its own. And in this discussion, Terry and I are going to try to give you an overview of the kinds of things practices need to look at and may need help with.
Good morning, everybody. This is Terry Spector. Making the appointment is the first contact with the patient, whether it's a new patient or for some episode of care. The people who are answering your phones, they represent you, and it's very important that the way they represent you as the physician and your practice and the business of your practice will continue through in your relationship with this patient. One of the things that's very important, as you see here, is office hours. It used to be that if you were a, quote, good physician, patients would come to you whenever you were in the office. Today, that is different. Today, you need to be in the office when the patient wants to come. We're often finding that with more and more working women, more demands on parents for after-school activities with their children, that the best time, rather than being evenings, which used to be a primary choice, is early morning. So when I go into a practice to do a review and I see they start at 10 o'clock and they end at 4 o'clock, they are closing the door on a huge opportunity for patient commitment. When the patient calls for the appointment, if you have whether you're working on forms or using a portal, it's important that you get as much information as possible. You need to do an insurance verification right after you make that appointment. Ideally, you're making the appointment a week in advance and you have plenty of time to verify it. Otherwise, even if you make the appointment that same day, you need to be able to run on your system insurance verification to know that the patient does have the insurance, what the copay is, and what the deductible is. Okay. The type of visit is important because you need to have some allocation of time relevant to what. Okay. New patients, of course, you want to get in immediately. It sounds very elegant to say the doctor is very busy, can't get a new patient in for a week or 2 weeks. Chances are they will find somebody else who will get them in more quickly. So an essential thing is to get that patient, get them in as quickly as possible. For any procedures, authorizations are essential. The rule nowadays needs to be that if you are doing any kind of procedure, you need to authorize it until you're proven that you don't need that. Okay? Let's go to the next slide. Your PM software should have an eligibility module, but you need to do the authorizations at least 3 days prior to the visit, because a lot of companies do this, can take up to 3 days to come back with an answer. Eligibility, again, that's where you're going to find out and confirm where what authorizations are needed and things like that. So going in and making the office's commitment to the patient is essential. And let me tell you, if your system is running properly, if money is written off because you're not getting paid, because you didn't get an authorization, when we handle an account, that needs to get written off in a special category. So you can run a report and know how much was written off because the front desk staff or your business staff did not get proper authorization.
Eligibility report.
Okay? The office forms and the consents are important. We all know about the HIPAA. They've done a lot of updating with HIPAA this year. It's essential. Consent for treatment, there are some variables by state, but again, any procedure, you should have a consent form signed. The easiest thing is to protect yourself. If you get it signed and you don't need it, no big deal. If you don't get it signed and you do need it, you're not going to get paid. We make the patients ultimately responsible. Obviously, if the insurance goes out of business, you can't assign patient responsibility. But it's very important for the patient to know what they are responsible for. And especially if somebody has a large deductible and you did a procedure that was $1,000 and they've got a $5,000 deductible, and now the patient has to pay you $1,000. First of all, you want to collect that money up front, and that's perfectly legal and appropriate. Secondly, you don't want the patient to be surprised afterwards because now they have to pay you. You cannot go wrong, and you will not have a problem if you make the patient aware and have them sign that they understand what their cost out of pocket may be. It's good for the patient, and it protects you, and it avoids any inappropriate or unhappy circumstance with your patient. You want to collect any money possible prior to the visit or procedure. Deductibles can be collected up front. One of the other things, co-pays must be collected before the patient goes in. If not, and it has to be pursued in collection, chances are you're going to lose about 50% of that money. And too many doctors over the years have dealt with managed care and said, well, it's $5, I'm not going to fight over that. And then it was $10, and then it was $20. Now a specialist is having a $75 copay, which in certain circumstances may be the bulk of the payment for the whole visit. So you cannot and you should not let any money due you go by the wayside. If you choose not to charge a patient, that's your prerogative. But just to let money go by because you don't want to bother the patient or upset the patient, that's ridiculous. If you set up the proper parameters early on with the patient, you will not have a problem with it. One of the other ways is, every practice should take credit cards today. People delude themselves that they're going to lose a lot of cash to credit cards. That's not the case. The cash payments have become so high that people are going for credit cards anyway, or else the other alternative is bill me. The money you collect today is your very best money. Another way with credit cards is to have a credit card on file situation set up, so when payment comes in from insurance company, money went to deductible, you have the authorization to charge that to the patient's credit card.
Now we're going to just talk a little bit about documentation and coding. Proper documentation and coding is money in the bank. As a management company, we've dealt with a lot of practices over the years, and one of the things we found, and we insist on with our clients, is that the only one who should code a visit are the physicians. Why? One, they know what they did. They know how much care they gave. They know how much time they spent with the patient. And they know the complexity of what they had to do to make these decisions of how to treat the patient. Okay, most doctors give very high levels of care to their patients. Most doctors don't document that care properly, and then they don't bill that documentation properly. Our scenario is that if you give the care, document the care, and bill the care. So if you give a 5-level care, document a 5-level, and bill a 5-level. As long as it's properly documented, you will not get audited in a negative manner. So it's really important that documentation is proper. We're moving into a world where we are going to be paid, the physicians are going to be paid for quality of care. When we talk, this is what we're talking about MIPS, which is basically pay for quality. It is really, really important in going down the line that you have a good AHR, that you do the required tests on patients that are required in your specialty, because this is going to reflect in your pay. 2017 is the base year for incentive payments. In 2019, there are going to be penalties levied on physicians who do not meet the criteria. And right now it's Medicare, but other insurance companies are signing on and are moving to a pay for quality scenario. One of the things that a lot of physicians who aren't trained in coding documentation, especially coding, is there are a lot of additional codes that are applicable to a visit the doctor may not be aware of, such as seeing a patient after 5 or on weekends and holidays. Some insurance companies can pay up to $40 extra on a visit if the patient is seen under those conditions. And there are many more codes that can be used to enhance payment for work that you have done. One of the things that all companies do is electronic scrubbing. I think, Terry, you need to talk about electronic versus visual scrubbing.
A lot of companies, excuse me, will tell you that they electronically scrub, or just say scrub, all of your work before they bill it or submit it for billing. What that electronic scrub is really the submission to the insurance carrier to the clearinghouse, and if it bounces back, then it's considered quote-unquote scrubbed, and you have to fix whatever problems are on the claim. The other part that most companies don't do, and that we're proud of ourselves for doing, is visual scrubbing. That means we have live scrubbers looking over every single claim before it's entered or submitted for billing.
Nice.
And what we're able to do then is to significantly raise the quality and the percent of clean claims or very clean claims going out. If we see a claim that may get through, but one of the procedures doesn't have a diagnosis code, or anything is wrong, or you put a diagnosis code that would apply to a visit, but you didn't check a visit, you checked a procedure. Any of these little missing things that throw the whole claim off kilter, we try to pick up, and we do pick up even before we electronically submit it. This means that the cleanest claim is going in, and this means that you are getting your money much, much faster. Also, it's very important to use proper modifiers. Claims will be rejected simply because, by the insurance carrier, simply because it is missing or you do not have the proper modifiers. Now, collection and denial management. It's a whole lot of work in that. Some people think it's very simple, and that what the insurance companies certainly are going to, quote unquote, pay you perfectly. And so whatever doesn't come in, you write off. That's just throwing away money, okay? First of all, as much as you, and as much as we're happy to have the process where you can electronically post payments, you also have to very carefully look at what the zero payments are, okay? If something is not paid properly, you need to be able to appeal it, resubmit it, and or make phone calls to get it corrected. Just because it is not paid quickly or easily does not mean that it should not be pursued. It's most important, the single most important thing. You cannot resubmit a claim until you find out why the previous claim didn't work or didn't get there. And we'll hear people all the time, well, if it's not paid in 3 months, we resubmit it automatically. Well, now you're just going to hit problems because you're going to have, it's going to come in as a duplicate, and it just creates more and more havoc. A claim is denied, a claim is not paid properly. You've got to find out why, and then you got to fix it. Electronic posting, as I started to say before, is certainly a great advantage. It doesn't always apply everything as properly as it should. So if you have three charges on a claim, it may pay the total amount or a single total, but it doesn't necessarily apply the payments per line item. We are very, very concerned about giving the physician a correct and a reasonable AR. I have doctors who think it's wonderful. They're very impressed that they have a $4 million AR. Well, that's because stuff that needs to be written off has not been written off. Things that should have been pursued are just left dangling in the system. Money is left, money that's due now from the patient is still left in the insurance carrier's bucket, so you can't see what the insurance carrier really owes you versus patient responsibility. So what we do and what we highly recommend is when a payment comes in from an insurance company, and it's a proper payment, you post what comes in, you've posted your copay hopefully in advance, and maybe now you're getting a co-insurance that the patient is responsible for, or money that the patient is responsible for because it went to deductible. At that point, we change the bucket of dollars due to the practice and put them in a separate bucket called patient responsibility. Okay? This gives you an opportunity to see a correct AR. Any money that needs to be written off gets written off appropriately or with the right designations, and you know where you stand. One of the things that we do for our clients is we look at what their write-off rate is. And most of us are pretty standardized for that practice. It doesn't matter how high or low it is, but it allows you to make projections. So when you look at an AR and you see you have a patient responsibility, that's after all the write-offs. So you know that's real money. You take the other money and apply the write-off rate, and you've got a pretty exact dollar amount that's due the office. And that's what you can use. It helps you plan your practice. statement cycle should start as soon as a patient responsibility amount is applied, unless the patient already is in a billing cycle because they owe money to the office. We send out, and we recommend this, 3 patient statements. If patients want a plan, a payment plan, or things like that, we're more than happy to work with them. But if you send out 3 patient statements and you get no response, no payment, no phone call, no question, nothing, it's like falling off the earth, then what you need to do is you need to make a collection phone call. If you speak to the patient or you try and reach the patient and you get no response, you leave appropriate legally safe messages on their phone. After that, you wait 30 days, and we recommend turning it over to a collection agent.
The longer you wait, the less.
The longer you wait, the less money you are going to collect. After 3 statements and a phone call, and at this point you have to figure you're at least 6 months into this claim. If the patient is avoiding you, you need to have a collection agency start making the calls. Otherwise, you just could write off the money because chances are you will never see it.
All right, let's talk about reports and analyses. This is crucial to running a practice. Most RCM companies, again, they do billing collection, they don't do management. Basically give you some reports every month on what you billed, what you collected, your AR, and really don't give you much more than that. Okay, that's not going to help you run a practice. Okay, we know that in well-managed practices, the accounts receivable over 90 days should be less than 10%. Most practices, 10 to 15%. Assuming that you don't have a lot of workers' comp or no fault, because that just delays the payments by the inactivity of the government. So we like to see the account 90-day, the accounts receivable over 90 days less than 10%. We have practices that we work with that take in 90 to 95% of their revenue within 60 days. And almost all our practices have less than 10% after 90 days. In practices that we review, do a review analysis of their billing and collection for them as a management company, we often find that more than 50% of their revenue is out more than 90 days. And this is a one little test that any practice can do to see if they need help. If your accounts receivable is over 90 days, is more than 20%, you need help. If it's over 50%, you need a lot of help and you're losing a lot of dollars. The other thing that as a management company we provide to our practices and our physicians are productions reports and analyses. So we'll do analyses for the practice on each physician, the range of codes they bill, the procedures they do, the collections on the procedures. We give a report every 6 months to a year, depending on what the practice wants, on each insurance company they're par with, the percent of that insurance company their patients are, so it's relative, so the insurance company with who they most use is first, and we look at the revenue based on each CPT code that the practice bills. We look at each CPT code that the practice bills and what each insurance company pays. And then we do an analysis which pays better and which pays worse. So if the practice is really busy and doesn't have room for more patients, they know which insurance companies pay the worst, and they can make a decision. The other thing is knowing what each physician brings in and the codes they bill and the number of patients they see is really important, especially in practices where there are salaried physicians and the owner is concerned about what the physicians are producing or what your PA is producing in order to run your practice. We give what we call an office revenue analysis to all our practices every month. This is an analysis of the practice. It includes, depending on specialty, the number of individual patients seen so far that year compared to last year, the number of visits, patient visits seen, the number of CPT codes billed per visit on the average, the number of well visits, the number of prevents, annual well visits for Medicare, and then leading to the amount that's billed, the amounts that's collected, the amounts that are written off, and using the write-off rate, a projection for what the work done that month will ultimately produce. In addition, we give them a column which actually tells them what we posted that month for them, and we update previous months to what was collected for work done in previous months. The ORA, our ORA usually shows that by 4 to 6 months, we've collected 98 to over 99% of the monies expected for our clients. And this is really important information to help the physicians run their practice. So we went over a lot of things today. The most important thing to take out of this is that every practice has to look at their AR, see what's out there. Really take a hard look at their systems, because RCM is not just medical billing, okay? These companies don't have the M in their RCM, and a lot of practices don't have the M in their RCM. Every practice needs a system for real revenue cycle management that actually manages the whole process from the patient making the appointment to collecting the last dollar. When we do evaluations, when we take over a practice with RCM, with a management component, we reasonably increase their revenue with the same production 20 to 30%. And we offer a free assessment to any practice. We will look at your billing, we'll get reports, and we will give you an analysis of what we think that you can increase your revenue with the proper office business systems in place. And this is very, very important.
I know when I listen to these things, there's a point where you feel overloaded. But I think the most important thing to come away with is the better you understand what is going on in your practice, and have people come in with what I call a third eye, who have not been in the practice, have not gotten into the groove, but is looking over the grooves, around the grooves, because you don't want to step in it. So when you get that third eye or clear, fresh look, it can be very, very helpful in seeing things, because we all know when we look at the same things too often, we really don't see changes and we really don't see what's there anymore. We can help you see the difference.
All right.
Thanks, Terry and Ira, for imparting just some of your wisdom and knowledge, and for explaining the differences between an RCM company and an RCM company. To everyone on the call, we very much appreciate you being able to attend. Please be in touch with us, give us a call for more information on how Medix RCM can assist you with true RCM capabilities, or if you're more interested in the Medix suite for your practice. Take care, and we look forward to being in touch.